Afternoon, good morning, good evening, wherever you may be, and welcome to this Urban Institute webinar, Using Demographic Data to Advance Health Equity. I'm Brian Smedley. I'm a senior fellow in the Health Policy Division of the Urban Institute. This event is part of Unequal Treatment at 20, an Urban Institute program of research to examine progress and challenges to advancing health equity on the 20th anniversary of publication of the Institute of Medicine report, Unequal Treatment, which documented racial and ethnic inequities in the quality of care, even after access-related factors are considered. In the 20 years since this report has been released, arguably, awareness of racial disparities in healthcare has increased, yet there has been little progress toward actually closing those racial and ethnic healthcare gaps. You can check out the full slate of Unequal Treatment at 20 publications and virtual dialogues behind the link in the chat. Before we get started, we'll go through some brief housekeeping items. First, this event is being recorded and the recording will be posted online afterward. Speaker biographies and related materials are also available online. Please see the link also in the chat for those materials. Note that all participants are muted, but you can type your questions or comments into the Q&A box at any time. That's the Q&A box. Engage with us online by using the hashtag #LiveAtUrban, and please take 1 to 2 minutes to complete the survey at the end of the event. It's my pleasure to introduce my colleague, Jennifer Haley. She's a Principal Research Associate in the Health Policy Division at the Urban Institute, focusing on maternal, child, and parental health and health care, Medicaid, and the Children's Health Insurance Program, and health equity. Her current research assesses opportunities for improved collection and use of data on race, ethnicity, and other factors related to coverage and care for children and families. Jenny, thank you so much for moderating this important discussion.
Thank you so much, Brian, and welcome everyone. I'm really glad to be moderating this discussion. We have such a great panel. As Brian said, you can read their impressive bios online, but very briefly, I will let you know they are Rodney Hood, Vice Chair of the W. Montague Cobb National Medical Association Health Institute in San Diego, Fontaine Lowe, Deputy Director of AAPI Data in the Bay Area, Tu Quach, President of Asian Health Services, a federally qualified health center in Northern California, and Kara James, President and CEO of Great Makers in Health. Kara also led one of the papers in the UT at 20 project. So I invite you all to come on screen and just briefly set the stage here that we're all well aware of the vast health inequities in the United States by race and ethnicity in terms of people's access to health insurance and health care, the quality of care they receive, the experiences they have, the type of treatment they get, and their health outcomes related to a variety of ways in which structural racism affects people's experiences within and without and outside of the healthcare system. And we know there are large health inequities across a host of other demographics like language, citizenship and immigration status, age, disability status, sex, sexual orientation and gender identity, or SOGI, and the intersections of all those characteristics. And so as Brian mentioned, it's long been established that the first step for reducing inequities in healthcare by race and ethnicity and other characteristics is to have data on people's identities to see where these inequities exist, and then to use the data to develop interventions to reduce them. We have seen growing interest in collecting individuals' demographic data and social needs data as well by the federal government and states, health plans, providers, employers, and others. Last year, OMB issued updated standards for collecting race and ethnicity in the federal government, for instance. But we know these minimum standards are not enough for the level of granularity that we need to assess everybody's experiences. And it's important not only to have the right categories to capture people's data, but also that the data are collected in the right way. And so teams here at Urban have been focused on a lot of these issues over recent years. Colleagues are dropping some of those links into the chat, but today we want to build on some of that prior work, specifically related to a project that a team here at Urban has been doing related to unequal treatment at 20, with support from the California Healthcare Foundation, looking specifically at the California context. So they will be releasing that work in the coming months, but today we'll be previewing some of the things going on in California with our panel. So let's kick it off with the basics. Collecting demographic data can serve many purposes and functions. So a most basic question is, why is it important? Kara, let's start with you. You previously served by directing the Office of Minority Health at CMS, or the Centers for Medicare and Medicaid Services, and you instituted some new ways for thinking about quality improvement and equity. Could you talk about that?
Sure. Well, first of all, thank you, Jenny, and to the Urban Institute for convening this important conversation, particularly at the time that we are in. And I think the most obvious reason why it is important to have this data is that if we do not, then we do not know where we are. We do not have an ability to measure our progress and to monitor changes. And so at CMS, some of the work that we did really was about increasing the collection of even more disaggregated data. So HHS was utilizing data standards that had more disaggregated categories for Asian Americans, Native Hawaiians, and Pacific Islanders, as well as our Latino community. So some of that was increasing some of that collection and making it more standardized, but also analyzing the data, because there's a lot of data that we don't look at. And if we don't look at it, then we don't know where we are. So increasing stratified reporting across Medicare and where we could in Medicaid and other programs, but also embedding health equity into our quality improvement programs and thinking about how we can incorporate that into star ratings and other spaces where we're doing that to incentivize quality. And then the last thing that I will just say to kick us off is thinking about how we map that, because what's happening in one state is not the same as what's happening in another. And so that ability to look more locally at some of the changes and challenges, be it in rural communities or tribal communities or other places, are also very important pieces that we had. So those were just some of the things that we had worked on while I was there, and the office has continued that work since I left.
Thank you. Rodney, could you share an example of using stratified data to identify and address disparities from your experiences as a provider?
Yeah, first of all, thank you. You mentioned in the beginning that this is a 20 years since the unequal treatment. And I should say I've been in this space for quite a while. And one of them was when I was president chairman of the National Medical Association. We saw data that showed there was discrepancies in healthcare. And it was the advocacy of the NMA that convinced Congress to fund the unequal treatment. And so the conclusions of unequal treatment would not have taken place without the collection of data. Fast forward to COVID, and I'm in San Diego. When COVID hit, there's a saying in the minority communities, especially the Black communities, when white folks catch a cold, Black folks catch pneumonia. And it was clear to us from the beginning that COVID was going to be different in different areas of San Diego County, depending upon where you lived and your ethnicity. We would there was a coalition forum that I chaired called the COVID Equity Task Force. It included multiple diverse providers, community health workers, community organizations, faith-based organizations, and we partnered with the county, who actually contracted with many of the members of that COVID to assist them in dealing with the most vulnerable populations. And the way they did it was they looked at the health equity index, knowing where the population was based upon where they lived, their race, their ethnicity, and specific community-based organizations were contracted with to deal with those vulnerable populations, specifically Blacks, Hispanics, Asians, and the immigrant community. And that coalition, we believe, we identified testing, treatment, outreach using data to show us where to put the testing sites. And we feel over the 3 years that we would not have made the impact in decreasing the impact in the vulnerable populations as far as COVID without that data. So, all problems require a solution, and solutions requiring knowing who, what, where, and why. And you don't know the who, what, where, and why without data.
Thank you. Well said. So Fontaine and Tu wanted to bring you into the conversation. You both think a lot about the technical aspects of gathering and using the data, especially, and also have a sense of what's going on the ground there in California. So where do things stand in that area? And what are been some of the important actions in California? Tu, we can start with you.
Great, thank you. And just wanted to say Happy Lunar New Year to everyone. Today's officially the Lunar New Year. Again, I work at Asian Health Services, a federally qualified health center. And in California, we've really have been pushing for data disaggregation when it comes to racial ethnic groups. So in 2011, AB 1088 was passed, requiring that there is collection from the Department of Industrial Relations and Department of Fair Employment and Housing for the Asian Americans and Pacific Islander groups. And then in 2016, we passed AB 1726 that requires expanded list of that. And then just recently this year, SB 1016 was passed requiring detailed health data for Latinos and Indigenous communities. All to say that there is a recognition that having detailed race and ethnic data is really critical when we're advancing on health equity. But the one thing I wanted to share, again, kudos to the amazing community groups and our legislative leaders for pushing that along. But in 2016, AB 1726 was passed. To this day, we are still working on how to implement it. All to say that even when you pass legislation, the implementation is often really critical work in it. And even though data has been collected and the state is the California Department of Public Health is getting some of that data, a lot of times we get the results back and they say, oh, well, it's missing, or a lot of people don't want to report it. And so we actually went deep and worked with the California Department of Public Health and actually try to identify through a data flow approach, like what are the real bottlenecks? Is it just because people don't want to give their race ethnicity? Is it the providers not collecting it? Or is it a data interoperability piece where systems aren't really talking to each other as much? And we found that while all of them influence it, a lot of times it was near the middle where people aren't communicating back to say, hey, providers, you have this data, can you send it on to us and we can receive it? And so through that work, we were able to work to really make sure that the data flows through. And I think my example is really about, hey, when we think about great legislation that gets passed and ensuring that data gets collected and reported, let's really think it through on how data flows through across and make sure that we identify the right bottlenecks, because often it's just not one area.
Hi, everyone. It's such a pleasure to join you all today. I'm Fontaine Lowe from AAPI Data. I also wanted to just kind of insert that I spent a number of years in philanthropy advocating for data equity, better data collection, to ensure that all the disparities in everyone's experiences and needs are reflected and accounted for in policy. I've been working a lot with Asian Health Services and others throughout the state on AB 1726. I can't believe we're nearly 10 years out and it's still not implemented. And I think it further just kind of reinforces that you need to resource and enforce it. There are other states that are farther along than California. I believe that includes Hawaii and Washington, because the work is very, very technical. And it also requires not only the technical expertise, but also really strong community voice, which I know Asian Health Services, along with many others across California, have been advocating for disaggregated data in the public health system. And it's an ongoing battle. There are many loopholes. Often there are many, I guess I'll kind of go into what I often hear as some of the challenges that folks come across, or maybe even excuses. That includes that it's too expensive, too intensive to do, but we have to start somewhere, because actually, as we all know, to actually treat the problems rather than prevent them is way more expensive, of course. There are often concerns about confidentiality, but there are actually statistical methods that have been devised over the years to account for that. And that includes differential privacy. So there are a lot of things that I think are kind of in our psyche around why we can't offer or we can't be reporting more disaggregated data that actually we have solutions for. And I think it's time for us to get out of that mentality and really think with more kind of a solutions-oriented mentality.
And you both have mentioned this data disaggregation and the need for granularity to identify patterns. Any other comments from either of you about that need for granularity?
I don't know, Fatin, did you want to answer that first?
I'm happy to. I'm happy to offer some perspective as certainly a researcher who's been around long enough to at some point have accepted the trope of, we just really care about the larger populations. And I think that is something that we need to get out of. We see very, very different outcomes. If you look across kind of the different subgroups, for example, just going to kind of pull up one of the charts from my work, includes educational attainment. If you look within the AA and HPI population, you see percentages of folks who have 4-year degrees or higher at 77% for Asian Indian or 57% for Chinese. But if you look at the Hmong population, it's 24%. If you look at Native Hawaiian or Samoan, it's 19 and 17%. So it is so important as we look at outcomes to look at that disaggregated data and understand, how can we better support or better, think about the systemic barriers that many of these groups come across. I think if we can understand that just because populations are small doesn't mean that they don't need attention or that they don't need, that kind of specific kind of data point just kind of aggregating it into other. I feel like we should, as a field, no longer accept that as the norm.
Yeah, and just to add on to what Fontaine had said earlier, oftentimes when we ask for disaggregated data, the response has been, oh, well, we'll worry about privacy and such. And I just wanted to say, as a community person, as an epidemiologist, we get those points and we really uphold privacy as a healthcare provider. And yet there's ways in which it can really inform us. So Dr. Hood had talked about COVID and the experiences. I just want to share for Asian Health Services, when COVID hit, we were one of the county funded areas and organizations that did a lot of testing in the community. And at that time, we were able to collect the granular data for Asian Americans and Pacific Islanders. And so we were getting real-time data, and we started seeing that while as an aggregated group, Asian Americans were, the test positivity was pretty low. When we disaggregated it, we found that the Vietnamese and some of the Southeast Asians were really high. And so not only were we putting out reports, it actually was informing us as a healthcare provider to go deeper into the areas of Little Saigon, of Oakland, and actually understand what was going on, which was there was actually crowded housing, there was not that much protection. And so working with that community, we were able to get those rates down really fast. And so all of this is to say the data is really important to identify disparities, but it's also really informative for the current practice as providers to do something real time. And so that's why we're always asking that, it not just be in a report, that data becomes available to folks and that's interactive in that community, as well as healthcare providers can use them too.
Thanks, Dr. Hood.
Yeah, I'll be very brief. I just wanted to highlight what they said. During COVID, there was a COVID equity task force, and one of our members, Dr. Happy Aranada, who is epidemiologist at the UCSD, presented many times showing that without disaggregated data, we were missing like the Pacific Islanders. And she really educated us, but not only us, but the Public Health Service. So that's critical. And it really helped them target certain populations that I don't think would have been targeted in the way they were targeted.
And if you don't mind that I chime in, certainly I think because my role at AAPI Data, I'm speaking to the needs of AAPIs, but there are many others too. I just also want to recognize, certainly for Native and Indigenous groups, I think that's often, a similar kind of set of excuses, as well as, with SB SPD 15, now that we will have a MENA category. And kind of certainly it'll take some time before that's actually formally guideline, like the fully embedded in our data infrastructure. But certainly that will be also another group to kind of pay attention to, as I believe disaggregation for the MENA group is very important as well.
Thank you all. I see there's a question about the maintenance of SPD 15 and the new era we're in. So maybe we could shift a little bit to that topic. You know, we expect the actions of the federal government will be very different over the next 4 years than they have over the past 4 years. And so, Kara, maybe you could give us a little bit of a look back as what had been going on in this area of data collection and use in the first Trump administration, and what this suggests for the role of the federal government as well as philanthropy in the coming years.
Yeah, so I think it's going to be an interesting time. That was, I think, the word I used the first Trump administration, and will continue to be an interesting time. What we saw in the first administration was honestly continuation of the work that was underway. So we didn't see a pause in that, but we did see, in terms of some of the analysis, reports that were being trimmed. So the National Healthcare Disparities, National Healthcare Quality reports, some of that information being smaller, and same with the Health US, which provides a lot of stratified data by insurance coverage, race, as gender, as well as income, and those reports got smaller. So there are, I think, some concerns about the what gets reported. I think also there are real concerns about what implementation of SPD 15 is going to look like, because going to the points that Tu and Fontaine made, we need resources for implementation, and it takes resources to change systems to change that. And I think, given what we have already seen, I think there is a real concern and question as to whether or not those resources will be given. I think also, in terms of the work that we have, there are, as a result of the Affordable Care Act, codified offices of minority health in many of the agencies of HHS. The CMS office was one of the ones that was established as a result of that. Same with FDA and SAMHSA, HRSA, AHRQ, NIH, and CDC, as well as the department, already had those offices. I think there is concern about what resources those offices will be given, which they support research, grants, other programs, and community groups to help be able to lift up and identify that information. We already saw some changes in terms of collection. So just in the past couple of years, we've had a number of states pull out of important data sources like the Youth Risk Behavioral System, how we know about what's happening with our youth mental health crises. And so I think there is also concern about that ability to leverage that information. That information is used by nonprofits, even by the states, to apply for federal funding and for grants to address key issues in their community. So there, I think, are going to be some significant implementation issues. And in terms of the role of philanthropy, it's a very important one. I wish we had more funders in the research and data space than we do, because we often have a dearth of that in terms of understanding. It's not as exciting as a meal program or food program that serves however many people, but it's critically important to having the information to know where we are, what progress is being made, what challenges still exist. And so would encourage our funders to think about how we're supporting information in a space where there may be an information vacuum to be able to continue the work ahead of us. At the same time, philanthropy cannot replace government. And so there are things that we do need to continue to hold government accountable for, to make sure that the work is continuing. Philanthropy can help, philanthropy can address some of those issues, but cannot be a substitute for government.
Thank you so much. Tu, I'm wondering if you could tell us a little bit about how any changes might be playing out on the ground in terms of collecting demographic data.
No, this is a hard one because we were also excited about SPD 15 and hoping that it will still move forward. I think it also signaled that there was an acceptance that collecting disaggregated and granular data should be the norm. And I think that if we can hold on to that piece, it's critical, because even though SPD 15 allow 18 months for the different departments to provide their plan, and then a 5-year implementation. We started already seeing some changes, that folks started working towards that as part of the norm. And so now with this new administration, we're worried that things may get changed, but it's important to put out a message that says, even if the government, which we hope will still push this forward, even if they were to pull back, we as a community, as philanthropic partners, need to push forward that this becomes a norm of how we report data. And I think that that's really key. At the same time, I have to say, as a healthcare provider on the ground, there are chilling effects all across, not from folks just using healthcare services, but also them wanting to report. We're starting to already hear that there's more missing information when it comes to not just race, ethnicity, but some of the specifics. Even SOGI becomes a huge issue. Language preferences, all of that. And so how do we still push forward on health equity that includes, data that's going to inform our agenda, and still acknowledge that there are threats that are going on at this point? And I just want to share a recent example. As we prepare our data and we report our data every year, we're looking at data like SOGI. We're looking at things that are required for federally qualified health centers to collect. And we're starting to get concerned. Even though when we submit the data, it is de-identified, we get concerned. And we have to think about it from all different aspects. How do we still push forward on data justice, data granularity, and also recognize the risks that are coming forward, every day with a new administration? And I just put that forward. I don't have an easy answer to that, but it is a major concern for us.
Go ahead, Kara.
Sorry, it too just made me think of something that I do want to also reiterate. We also need to do education around the use of data, because as we're getting to AI and sort of this space of pulling resources and data together, we can unintentionally do real harm to communities in ways. And I saw in the chat questions about getting down to that local level and geographic. When you have small numbers, the potential to inadvertently identify somebody becomes real. And I think that as we are moving forward, that data literacy is also an important piece of the conversation that needs to happen, and also cannot, just want to plus one the notion of people's willingness to provide the information for fear of what may be happening and what may be coming forward.
Absolutely. Just want to underscore that I think that, we've seen both kind of the sense of fear, the chilling effect, as well as AI will change the game in many, many important ways. But I also want to put out there that, in some of AAPI Data's work, where we found, I think there's kind of two sets of realms of data to kind of think about. There's both survey data as well as administrative data that's collected in the normal order of business of like providing various services. Survey data is typically where you have kind of that stronger disaggregation. Administrative has been kind of weak. In the past administration, we focused a lot on federal level work. Moving forward in this administration, I think the anticipation is some key states will have opportunities to move at the state level, potentially, depending on how some of these various executive orders are going to go through. And I just kind of want to put out there, I think going back to Kara's earlier comment of just the role of philanthropy, and all just broadly people who fund surveys and research, that continues to be a place where disaggregated data can still happen. Feeding more resources into the system such that there is a stronger system for collecting that data is really important. When I was at the James Irvine Foundation, we funded a study on AAPI workers, and I realized very clearly there's a supply and demand issue. If we don't continue to fund research that's offered in language, we don't continue to support field houses that go out into the field in those communities, those things actually, for the most part, have mostly disappeared. So I think that, while it feels like it's mainly a kind of a public dollar issue, there is actually a lot that us as consumers, we can be asking questions, and we can be funding research that actually supports the data that we need.
I just wanted to add, as we're talking about this, in healthcare, and I'm sure all across, we're actively preparing for, immigration enforcement officers to come to our sites, and we're preparing for the physical threat to our patients and our staff. And yet, from a data perspective, we also need to prepare from that lens too. That does not mean stopping to collect, which I think is a sort of a nuanced response. Like, don't collect all this because it could be taken. But how is it that we can collect in a way that ensures privacy and safety? I think it's something that we should all put our heads towards, because this data isn't just for research. It's really informative to the practice and care that we provide, the high quality of care. And so I would hate for us to pull back, because as someone once told me, once you pull back, when we're ready to go forward again, we may not be able to start again. And so it's important to think through from a long-term perspective rather than the moment, and still be very cautious and be guardians of very sensitive data for our patients, but not kind of respond and be reactive to some of the fear as well. Yeah.
Thank you all. Any other thoughts on the current climate? I'm also wondering, oh, go ahead, Kara.
I was just going to respond to one of the questions in the chat about the offices of minority health. And in terms of the DEI order, there was a review, I think as part of that for all of the positions. The concern is that other than, may get this slightly wrong, NIH, CDC, and the HHS offices have appropriations. The rest of those offices do not, so their budgets can be completely curtailed. Those were budget conversations, sort of budget fights that in 2020 I was having to deal with myself as we were coming to the end. So you can have an office that exists with one person that meets the letter of the law, but no budget to do any work. And so there's not much, I think there's some advocacy in that space as well, of just being able to see what's happening. And again, that insight into the information that's coming out. Those offices do important work and support work in communities as well.
Thank you. I wanted to bring Catherine Haynes on camera to join us, and also just remind folks during this transition to feel free to keep putting questions in the Q&A box. Catherine Haynes is a senior program officer in the California Healthcare Foundation's People-Centered Care team. And like with our other panelists, you can read her full bio on our webpage. But CHCF was part of the group of funders for Unequal Treatment at 20 and project officer for Urban's research in California. So welcome, Catherine. So glad you could join us. Would love to bring your thoughts in on these questions. But more generally, I've heard you talk about the ways in which racial equity and addressing healthcare quality have been siloed, and wondered if you could start by talking more about this and share what needs to happen to close those gaps.
Yes, what we found in work that we did with RAND, and in a recent RFP for delivery system anti-Black racism work. First of all, I should mention that I run a funding portfolio on Black health equity at California Healthcare Foundation, which typically covers Medi-Cal enrollees, but because inequity crosses socioeconomic lines for Black people, mine is not limited to the Medi-Cal population. And what we found both in the RAND work and the recent responses to the RFP is that there were people who have expertise in equity, and there are people who have expertise in quality improvement, or patient safety as a subset of quality improvement. And those, it's very hard to find bodies that have both of those expertise. And my thought is that, so we're doing this, we have 8 grants running right now in the delivery system in California, and they are doing quality improvement work, and there's some technical assistance with that. And there are also those in that group who do have big organizations that have both areas of expertise at their fingertips. And so there's going to be a sharing. Our next effort will actually be to work with quality leaders to do equity quality improvement projects. And I think it's important because in healthcare, there's a whole infrastructure for quality operations and patient safety that RAND found did not typically include race and ethnicity and language data in those operations. And they should very much be in those operations because the risks that patients face in the health system differ by race, ethnicity, and language proficiency, actually. So it's time for us to invest, and I will be investing and continuing to invest in bringing those two, instilling quality improvement and expertise in people who have equity background and vice versa.
Thank you. And Kara shared some great thoughts on the role of philanthropy in this moment in terms of leveraging data for health equity, and wondered if you could talk more about where those additional investments need to be.
Yes, we have a study that was just concluded. There'll be 10 case studies that we'll release in the next month or so about organizations that are, in fact, using race, ethnicity, and language data in quality improvement in California. It's a wide variety. And what they found was leadership. Leadership is key. The leadership has to make it a priority. The actual collection of data, a robust data system. So the ability to collect, analyze, and share data, that's critical. And then a strong quality improvement, quality operations function in the organization, and the ability to get the data to people that have line of sight for improving care. So that those things are really necessary. And I sit in California where we have a lot of healthcare foundations, but many of them have moved upstream. Right? Very few of them are working with, as California Healthcare Foundation does, with the delivery system. And so I work on getting the right measures, making sure that we have measures that are relevant. And when it comes to finding, right now, we're doing something with the Commonwealth Fund because that's who we could find to help co-fund us. We're a little foundation. We're not the endowment. To try to test comprehensive measures of equity in situ in delivery systems. And so we need that help. But there's another role I think is really important. You heard about the reluctance that people speak of people to give their data. And I believe that foundations, including those who've really moved more in the public health realm or who are working on social determinants of health, healthcare may be a small part of health, but the truth is that patients do have a voice. They can affect their interaction with the providers that serve them. Patients, we haven't talked about the role of patients as activists and the role of data and giving data as an act of assertiveness, right? As an act that helps patients hold the healthcare system accountable. And the healthcare system, I believe, can do everything it can to reassure people that they're not going to use data badly. But I'm not sure that we've told people why it's important for them and their communities to give those data and the power of data and the power of standing up and being counted. And I think if you zoom out and you think of the power of being counted, there's a lot of things. There's giving data. There's complaining formally. Our colleagues at Aviderus, a Black-owned research firm, found that 59% of patients don't have a clue how to complain. They don't know how to do it. So I think foundations who aren't working as close to the healthcare system as I am, but who are working with trusted sources of community information, can fund those organizations to take on this effort to help people have healthcare literacy, to know how to navigate the health system so that they can assert their rights because we have them in the healthcare system. And that would be a big compliment to all the work that is currently happening in the regulatory environment in California and in delivery systems in California.
Thank you so much. That's a great segue to our audience Q&A, because we're seeing some questions here about community engagement and data collection and use. So wanted to open these questions up to the whole panel. In how can states, this is the first question, how can states work more with community-led organizations, academia, and other agencies to get assistance with obtaining and using data?
Who wants to take that?
I can share our experience so far in California. I mentioned AB 1726 that was supposed to be implemented in 2022, and we're still working on it. But I think the California Department of Public Health has been good about starting a working group that meets monthly. And we as community organizations join that so that we're working together. Because even as the law has passed and there's supposed data submission, we weren't seeing enough of it. And that it wasn't very complete. So I think it's important to collect data, but ensure that you have complete and accurate data, or else it could be very harmful. And so in that, we work with the California Department of Public Health to understand. And I want to point out that, it's not like we have this magical data warehouse. It's by system. You have vaccine data, you have infectious disease data, you have cancer registry. It is mind-boggling. And each one of them run by their own system and have their own set of issues. So literally, we've been tackling each of those separately. But it is a great example of how community can work with government to promote data equity and data justice so that it comes back and helps the community. And in it, as we're working through on, how to, to Catherine's point, how to ensure that communities are providing that, patients are providing that, they're going to trusted providers who will care for their data. And then when it gets submitted, that's used properly, but ensuring that government actually reports it out in a useful way for communities. I saw the comment, the question about data fatigue. Community has to feel like there's benefits to their members to want to keep, investing in this. So it's important that there's trust built and that we see action. So that's a good example of starting a work group where everyone is putting their best minds together to make this work because we all want the same outcome.
Rodney, how about you?
Yeah, I think it's critical, but I think, we're talking about the state. I've been in California over 40 years, and I think the state of California, for the most part, gets it. And I think the community-based organizations need to interact in a relationship with their local healthcare communities. And I mentioned the COVID Equity Task Force. We had a great partnership with the Public Health Department in San Diego. And they granted us interaction, not just these were private physicians, federally qualified health systems, et cetera. Even after COVID, some of the health plans saw the benefit of the community health workers that we were doing with COVID, who then contracted some of the local community organizations to continue to work with the health plans to target certain ethnic populations, because now they saw during COVID, blood pressure, diabetes was getting out of control. And I have a local multicultural health foundation in San Diego, and we were approached and contracted with 2 health plans to help reach African-American population, not only to improve testing in COVID, but to improve hypertension and diabetes. So I think it begins locally.
I just wanted to note that in a survey done by our grantee Ivitaris of over 3,300 Black Californians, the vast majority, like 98%, asked for more community-based education about how to navigate the health system, not about diabetes, but about how to navigate the health system, and more community-based advocates or companions to go with them to help them navigate the health system. So there is actually a community, this would indicate there's actually community demand for this kind of help and an appetite for learning how to work with the health system. And I think that's a funding opportunity. I think it's an opportunity for community-based organizations, and it may well be an opportunity with CalAIM for community-based organizations to step up and get paid for that work.
And I would just add a couple of things. I think one, helping to support that, create an advocacy base for the data infrastructure, because as we're talking about all of these systems, these legacy systems, how they get plugged into one another, how they get changed, how they get amended, the ability for people to access those and get the data are so important. And we don't really invest in our data infrastructure. We don't invest in infrastructure, period, but we need to do more of that to be able to help make it more accessible and usable in ways that communities want. The other thing I think is, an opportunity to support researchers from the community who can get in and ask the questions that they're most interested in, because we all sort of research from different spaces, but making sure that we're supporting that. That was something that when I was at CMS, we did through our virtual research data center, providing support for people who are interested in researching around health equity and disparities. And I think the, community connections. And so when I think about, enrollment in the marketplace, we saw that completion of that data and provision of that varied significantly by the enrollment channel that was used. People who enrolled with a navigator were much more likely to report demographic data than those who went through other channels. So I think that ability to have that connection, explain why it's important, how it can be used, can also be helpful in those touch points. And then to bring it down to quality, I would just end, sort of with Catherine's point, and thinking about those quality measures, how we're engaging community in what matters to them. We measure what we can, which is not always what we want to and what we need to, but we think about, patient and family-centered groups that are engaging. We don't necessarily measure what they are caring about and how they think about quality. And so I think how we engage community in the development of quality measures, in the identification of those, is really important as well.
I'm nodding so much to everything that my colleagues are saying here. And I think what I would add, we do work nationally at AAPI Data, and we offer a lot of TA to various community groups and trying to get their local state departments to pay attention to their need for disaggregated data. So I would just kind of underscore what Catherine said earlier, that there is a desire. And I think particularly for communities that are highly ignored and invisibilized, you'll find so much energy. But they're often folks who don't have necessarily a lot of capacity, because we don't all have an Asian Health Services in our neighborhood who's doing that advocacy for us, right? So they're like direct service like groups who are kind of a one-stop shop for their community. They are academics volunteering their time on the side. They are folks who are trying to fit in this advocacy work alongside full-time jobs, and really doing it out of passion. And I think the thing that I would say is, and I think from the systems level, from the state level, it takes some level of capacity. Someone who is dedicated to building those relationships, building that trust, especially amidst the current kind of context of so much fear, that is so important. And it's in order to do it right and to meet communities where they are and to build that trust, it actually requires dedicated capacity to be able to do that right.
Yeah, and I'm agreeing with everything that's being said. And then I wanted to plus one on supporting and investing in researchers from the community. That is so critical. And in my experience, just learning so much from the Native Hawaiian and Pacific Islander community, even though they often group us together. One thing I've learned from some of my colleagues, and I think this is a question that was put in there, is, how do you look at the data around multiracial groups? And so what I learned from my colleague is you got to do it alone and in combination, because if you take out the in combination, you actually are unintentionally, there's erasure of groups, particularly for Native Hawaiians, as well as for some of the Native Americans and some groups where there has been a lot of interracial aspects in that. And if you don't account for that, and there's top coding of how we do things, that is really harmful to these communities. And so a lot of that comes out because researchers from those communities are speaking up and making sure that we're analyzing the data in a way that represents their community, that doesn't unintentionally erase them. And then the last piece is the piece around surveys that have been developed for other mainstream communities that have never given consideration, not just from a language perspective, but also from like the needs of that community. And only when we invest in those that come from the community could we hear a lot of that. And I don't mean invest in just like a fellowship here and there, but fully invest in the community researchers so that they are impacting our scientific field as well.
Go ahead, Rodney.
Well, I'm gonna, we've been talking about data, the importance of data, why, our experiences, but what's the solution? What's going to change and really make it happen? I've been a private practicing physician for over 40 years, and I learned what I call the Trinity of medicine. Somebody once told me, Rodney, you're a good doctor, but you know nothing about the medical Holy Trinity. I said, what is that? He said, it's medicine, policy, and finance. And it's the policy and finance that control everything we're talking about. Total transparency. I got a lot of friends in healthcare and whatnot for a long time. I believe in unisource healthcare, Medicare for all. That's my wish. That's not our reality. In order to make this happen, there's a business side of medicine that we need to understand, I think, to make it happen. There are 2 articles that were published in the Journal of the American Medical Association in 2023, one sponsored by the National Institute of Health, looking at health disparities, and found that excess mortality in years and potential life loss in the Black population over a 22-year period costs greater than 1.63 million lives. See, that's the human cost, quality. That's what we've been focused on. There was another article in JAMA 2023 by an health economist, and the title is The Economic Burden of Racial and Ethnic Health Disparities, found that in the year 2018, the US health system, because of health disparities, cost $451 billion with a B. So this health disparities is costing us too much money. If we had a solution, and much of what we're talking about, we can't get the solution without this data. Is there an example? There was a project I was involved in some time ago with an innovation grant from the CMMI with a Dr. Jeffrey Brenner, where he came up with the concept of health spotting. We recognized that 1% of these patients we're talking about cost the system 20 to 25% of the cost. If you increase that to 5% of the patient population, that's 50%. So there was a program designed to target what we call super utilizers. And by doing all the things we're talking about, community-based organizations, community health workers, social workers, surrounding these super utilizers with community support, we were able to decrease hospitalizations in ER, which is the major cost, to the point of over 3 years saving $15 million. It led many of the health plans to want to contract with us now to help them manage some of these heavy utilizers. These were patients in the beginning nobody wanted. They were all Medi-Cal or Medicaid. And however, if you managed them well, there was significant savings, which then could go back to build that network of community-based organizations. Providers benefited because now the quality measures on these difficult patients were getting better. They were getting paid for that. The hospital benefit because now they're in risk management things where they get paid to keep them out of the hospital, and the patients benefited. So and I'm bringing this up because we're in a new paradigm where people are saying they don't want to hear DEI. if we collect this data, develop strategies to decrease disparities, we're saving money. And I can guarantee you, no matter what side of the aisle we're on, everybody's going to be interested in saving money.
I just want to echo this, if I may, because people have asked me, well, now in this era that we're in, how do we sustain these efforts? And the community practice that I funded, we're having a meeting in the next 10 days, and we will have Health Begins train them in using the ROI calculator, because we often do not collect or even impute the financial benefits of some of the work we do. And I think it is imperative. It's always been imperative for sustainability. When I was at Kaiser Permanente, I did matching grants, and we required that part of it, those kind of financial data, to be collected too. It's imperative at this moment that we actually look at the hard dollars and cents, because there are costs in average length of stay, in return to hospital out of discharge, after discharge, that are absolutely correlated with race, identity, and language. And so I would admonish everyone to beef up their skills at looking at the financial cost of disparities and the financial benefit of intervening on those disparities.
Yeah. Sorry, I know you want to try and wrap us up. I'll be really
Yeah, go
quick
ahead.
because I want to plus one and provide a cautionary note in the cost. And I think that one, I will just say that absolutely, as health disparities, health equity researchers, we have relied way too long on moral assuasion to get people to change their behavior, and building that business case for addressing health disparities is critically important. The caveat, I think we rely too much as a country on costs as the outcome of quality. And if we are reducing costs in a population that already has access challenges, those costs, you don't quite see as much of the savings. And I think about the ties this all together, that the paper that was done by Obermeyer to look at the algorithm that was used for care coordination with United Healthcare built on cost alone. And the cost savings showed that the communities who were sicker, who happen to be people of color, less likely to be referred for care coordination. So just as a cautionary note, that we can't just rely on, and I'm not saying that that's what either of my panelists are suggesting, but we do need to do a both and absolutely build that business case for health equity, look at the benefits, but be careful about how we look at cost as just our only outcome. And that is where our society is, particularly, which we're not talking about here, but I will just throw out private equity. And so concerns about what that means for health equity going forward.
This is a great conversation. Go ahead, Rodney, and then we'll.
I totally agree with the last comment. So, however, ignoring it is not going to get us there. So we need to integrate it. I can tell you the study that I looked at, most of them were BIPOC community. They were African American, Asian, etc. And the savings was there. And we didn't know that without the data. And if the health plans found it very helpful then to work with the community base, because they couldn't do it. You mentioned the United Health Plan. Most of them have these complex case management things, but they're not working with community-based organizations. They may see a 5% decrease in savings. Using community-based organizations, you can see up to a 50% savings. That's the argument you need to, and they should get paid for it.
Thank you all so much. I'm going to do a final lightning round question for each of you. So we're at unequal treatment at 20. Imagine now it's 20 years from now. What would you like the state of health equity to be? What milestones or markers would we see along the way? Feel free to jump in with that theory.
I would like to see, in our IOM quality work, there is no division between health equity and quality. And I would like to see that this not be a question. It is fully integrated into how healthcare functions and not seen as a separate issue.
Plus one. Not only not seen as a separate issue, we don't have separate funding lines for it. It is just standard operating procedure and business as usual. I think that obviously we would want those outcomes. And I think the other thing I would just add is that we actually have a patient-centered system that people feel is working for them, navigable and affordable.
I would love to see data that accurately and appropriately depicts the many diverse communities that are served, and that data gets used and actually reported back in a meaningful way to community as it is owed to them.
Yeah, I agree. I like to see us not needing to look at the data and look at the differences, because most of us don't know the difference between equal and equity. We need equity to get equal. So I'm hoping that this equity phase leads us to equal. And one of the things I've always told my colleagues and patients, as a physician, I'm working hard to eliminate my job. So I'd like to see the need for fewer physicians because we've been so successful at this.
I think we've talked so much about data, so I'm going to try to bring it to a little bit of just, you know, my human experience of just the community I see around me. You know, I want our older generation, like my mom, I want her to be able to find a therapist who speaks Cantonese. I want to look around in my community and find that they're not ignoring significant health issues because they're fearful of either engaging the system or of the costs. And that's literally like, I don't really have teeth to eat. I want them to just have the access to the basics and feel comfortable in accessing those basics. And hopefully we can get to that point, both in terms of our systems that offer that kind of care, as well as the accessibility, both in terms of language and in terms of culture. Because I think that there's a lot that's lost in translation in a Western system, you know, between individuals who understand their health and healthcare very differently.
Those are so many incredible insights, and I hope all of you watching will join me in a virtual round of applause for our excellent panelists and all of these amazing insights. And we had some great questions. I'm sorry that we couldn't get to all of them, but we appreciate our panelists' time so much. And thank you all for joining us today, and hope you all stay well. Have a great afternoon. Thank you.